More than skin deep. Diagnosis and therapeutic management of psoriasis in female patients. Welcome to Clinical Minute. Laura is a 40-year-old Caucasian female who has recently moved to the area and has come for her annual well-woman gynecological exam. You are also her primary care physician. She does not have any gynecological concerns. However, she presents with a 1-year history of worsening thick pink scaly plaques on her back, abdomen, thighs, and arms, with additional moist red non-scaly plaques under her breasts, axillae, and intertriginous folds. Her lesions are pruritic. She is distressed by the increasing distribution and thickness of these plaques. She has previously been treated with topical antifungal cream. You think she may have psoriasis. You know that psoriasis is a chronic, relapsing, and remitting inflammatory skin disease that can be highly variable in morphology, distribution, severity, and course. You know that the different forms of psoriasis are typically identified by their hallmark appearance. Plaque psoriasis is the most common, presenting as well-demarcated raised pink to red patches with silvery white micaceous scales. Plaques most often appear symmetrically on knees, elbows, trunk, the lumbosacral area, scalp, and extremities. Guttate psoriasis is an abrupt eruption characterized by teardrop-shaped small papules. It typically starts in childhood or young adulthood and is often triggered by a streptococcal upper respiratory infection. Inverse psoriasis presents with painful, well-demarcated, symmetric, erythematous plaques in body folds. They may appear smooth, moist, and shiny, and typically lack scale. Pustular psoriasis consists of small, purulent papules that may arise spontaneously in normal skin or less commonly within pre-existing plaques. These are not contagious. Erythrodermic psoriasis is a rare, severe form that leads to widespread erythema and scaling over most of the body. Pruritus is common. Skin desquamation and peeling with resolution are expected. Sebopsoriasis represents an overlap between psoriasis and seborrheic dermatitis, presenting as pink-red papules and plaques with greasy yellow scale, usually on the scalp and face. Patients with nail psoriasis typically have clinically evident skin psoriasis. Nails most commonly demonstrate pitting, oil spots, or onycholysis. Other changes include ridging, grooves, and splinter hemorrhages. Psoriatic arthritis is a manifestation of systemic inflammation. Common symptoms include inflammation of the interphalangeal joints of the fingers, peripheral arthritis, spondylitis, and sacroiliitis. You recall that while the etiology of psoriasis remains unclear, there is evidence for genetic susceptibility and immune dysfunction. Psoriasis can also be provoked by environmental and internal triggers, described subsequently. As no permanent cure exists, treatment is based on symptom control. You also know that many patients with psoriasis have physical and mental disability, comparable to or worse than that of patients with other chronic diseases such as cancer or arthritis. Patients with psoriasis often feel stigmatized by their disease. This may contribute to low self-esteem and affect the ability to develop relationships. The chronic nature of psoriasis, lack of control over unexpected outbreaks, feelings of shame and embarrassment with skin exposure, social avoidance behavior, and limitations in daily activities, occupational, and sexual functioning may all contribute to diminished quality of life. You recall reading that severity is determined based on the percentage of body surface area that is affected. Mild cases affect less than 3% BSA. Moderate cases affect 3 to 10% BSA, and severe cases affect more than 10% BSA. Under normal circumstances, The skin rejuvenates about every 28 to 30 days. In psoriasis, new skin cells are generated about every 3 or 4 days, with the buildup of excess dead skin cells on the skin surface. It appears that innate and adaptive immune responses contribute to the complex inflammatory process underlying psoriasis. In addition to idiopathic spontaneous onset, triggers such as physical trauma, HIV or other infection, stress, medications, endocrine dysfunction, alcohol consumption, obesity, and smoking may start a cascade of events that include the formation of DNA LL37 complexes, activation of plasmacytoid dendritic cells, and secretion of IFN-A. You know that studies have supported the concept that interactions between dendritic cells, T cells, keratinocytes, neutrophils, and cytokines released from immune cells likely contribute to the initiation and perpetuation of the cutaneous inflammation characteristic of psoriasis. You are aware that the mean age of onset ranges from 20 to 30 years of age, with a second peak at 50 to 60 years of age. A significant number of women develop psoriasis during their reproductive years, when physiologic changes of pregnancy may influence its development. You know that a dermatologist or primary care physician can usually diagnose psoriasis by examining the skin. It is important to obtain a thorough medical history and determine if there is a family history. Psoriasis may resemble other skin diseases, such as eczema, seborrheic dermatitis, lichen planus, ringworm, or pityriasis rosea, which can make a definitive clinical diagnosis of psoriasis more difficult. Biopsy will help differentiate these disorders if needed. You know that approximately 80% of patients with psoriasis have mild to moderate disease and can be treated with topical agents, which generally provide a high efficacy to safety ratio. It is recommended that potent agents, such as strong steroids, be used on a short-term basis to achieve rapid improvement, after which patients should be instructed to use these only intermittently for long-term management, or switch to a less potent agent. Non-steroid agents may be used on alternate days for continued management while minimizing the risks of long-term daily steroid use. Topical agents may also be used adjunctively in patients being treated with phototherapy or systemic therapy. Topical corticosteroids are considered the cornerstone of treatment for the majority of patients with psoriasis. The mechanisms of action include anti-inflammatory, anti-proliferative, immunosuppressive, and vasoconstrictive effects. Corticosteroids range in strength from low-potency over-the-counter preparations of 1% hydrocortisone to high-potency preparations such as clobetasol propionate. The choice of the appropriate corticosteroid should take into consideration disease severity, areas being treated, patient preference, and patient age. Lower potency corticosteroids should generally be used for limited periods of time on the face, intertriginous areas, and areas with thin skin. In other areas, mid or high potency agents are generally recommended as initial therapy. Patients with thick chronic plaques often require treatment with the highest potency corticosteroids. It is important to note that these medications have a Category C risk. Women who are pregnant or trying to conceive should be counseled about the risks and benefits of topical agents. Local adverse events of corticosteroid use include skin atrophy, telangiectasia, stria, purpura, contact dermatitis, and rosacea. An important systemic adverse event to be aware of is hypothalamic pituitary adrenal axis suppression, with long-term use of mid and high-potency corticosteroids. You know that Class I corticosteroids should be limited to 2 to 4 weeks of daily use. They are safe for long-term use when breaks are taken. For example, patients may use them Monday through Friday with weekend breaks. Breaks dramatically reduce the incidence of side effects while allowing for adequate treatment. Patients can use an alternate steroid-sparing therapy on non-steroid days. The maximal weekly use for Class I corticosteroids, clobetasol and halobetasol, is no more than 50 grams. You order 4 mm punch biopsies from an inframammary moist plaque and a pink scaly plaque on Laura's back. You initiate topical clobetasol on Mondays through Fridays for all areas other than body folds. You instruct Laura to use the clobetasol only on Mondays to Wednesdays in body folds to limit adverse events. You intend to prescribe the topical medication only for short-term use as a transition to systemic therapy because topical steroids are burdensome to apply and are generally of limited utility for diffuse disease such as Laura's. After Laura leaves, you review the options for systemic treatment. Phototherapy has been shown to be highly effective and lacks the systemic toxicities and immunosuppressive properties of systemic and biologic treatments, so it may be a preferable option during pregnancy. UVB phototherapy is most appropriate for patients with less than 10% of BSA affected who have not responded to topical treatments. Psoralen ultraviolet A, or PUVA, has a pregnancy category C status and should be avoided during pregnancy. Excimer lasers are considered appropriate for adults with mild, moderate, or severe psoriasis covering less than 10% of the body. A consideration of phototherapy is the requirement for office visits 3 times a week. Laura returns for a follow-up visit. The biopsy results confirm your diagnosis. You start Laura on methotrexate with folic acid supplementation and NB-UVB light therapy. Since you know that methotrexate is pregnancy category X, you make sure Laura understands that risk, is not pregnant or planning to become pregnant, and is using reliable birth control. You plan to transition to a biologic medication such as ustekinumab or secukinumab after 3 to 6 months, if clearance is inadequate. Laura's insurance requires failure of alternative methods prior to approval for treatment with biologics. You know that despite the recent availability of biologics, traditional systemic therapies, with their oral route of administration and relatively lower cost, continue to play an important role in the treatment of psoriasis. Although minimum BSA, usually 10%, has traditionally been used as a prerequisite to initiating system therapy, a subset of patients with limited disease have debilitating symptoms which make systemic treatment appropriate. You are aware that methotrexate is the most commonly prescribed traditional systemic therapy worldwide for psoriasis. It is generally given as a single weekly oral dose. Common and generally minor toxicities include nausea, anorexia, stomatitis, and fatigue, which most commonly occur at the time of administration. Methotrexate is associated with hematologic toxicity and hepatotoxicity. Hepatotoxicity may warrant liver biopsy consideration. It is an abortifacient and a teratogen and FDA pregnancy category X. It is absolutely contraindicated in women attempting to conceive. Cyclosporin, acitretin, and apremilast are other systemic options. You know that biologic therapy is typically implemented when traditional systemic agents fail, are poorly tolerated, or are contraindicated. Biologics are indicated for moderate to severe psoriasis and psoriatic arthritis. They are given by injection or intravenous infusion. Most are pregnancy category B. You remember that the National Psoriasis Foundation recently indicated that the preferred assessment instrument in clinical practice is body surface area. U.S. experts agreed by Delphi method that the acceptable response after treatment initiation should be either a BSA of 3% or less, or BSA improvement of at least 75% or greater from baseline at 3 months after treatment initiation. Target response at every 6-month assessment during maintenance therapy should be BSA of 1% or less. Before she leaves, you counsel Laura that nutrition should not be overlooked. A gluten-free or a low-calorie diet have both been shown to induce a statistically significant improvement in clinical psoriasis. Oral or topical preparations of vitamin A therapy have proven most effective in treating psoriasis when complemented by additional treatments. Similarly, oral or topical formulations of vitamin D have proven beneficial, particularly in combination with topical corticosteroids. Combinations of supplemental selenium, coenzyme Q10, and vitamin E have been shown to improve severe forms of psoriasis. There is some support for the use of omega-3 fatty acids. Alcohol is the dietary factor that impacts psoriasis most negatively. You also recommend twice daily all-over moisturizing with ceramide-based moisturizers to improve treatment penetration and efficacy of topical preparations. Laura should use gentle skin cleansers. Avoid antibacterial cleansers and fragranced moisturizers and makeup. Sun may be helpful for psoriasis plaques only if there is no sunburn, which may cause worsening of disease. Laura asks if there are any alternative therapies for psoriasis. You know that complementary and alternative medicine use is common among patients with psoriasis. You tell her that you have read about some options and are prepared to discuss the potential benefits and side effects. You give Laura a handout with further resources and ask her to return in 1 month for an evaluation. Once she is on stable therapy, she may be seen every 3 to 6 months for ongoing management.